Well, we're at 2 past the hour, so I think we'll get started. Thank you everyone for registering and being here either live and on the live stream or perhaps on the recording afterwards. And thanks also for those of you who submitted questions. I did try to address as many of them throughout my talk. And we've still reserved time at the end to be able to answer some Q&A that you can enter in the Q&A section of the Zoom. So today's topic is demystifying dementia, talking about some breakthroughs in diagnosis and treatment. We'll hit some of the headlines that you might have heard about in the last couple of weeks. But I thought I should probably explain a little bit about who I am and why it is that maybe I'm the right person to be talking to you about this today. Let's see if we can get our slides to advance. There we go. So a little bit of a bio. You may have guessed I have a Northwestern connection. So I was an MSTP, did my PhD in cell and molecular biology. More importantly, though, it was on the tau protein, which you'll hear quite a bit more about later today, and in the context of Alzheimer's disease. Finished my MD at Feinberg as well. Then I moved to Washington University, which is where I am now, for my residency in neurology. And then I further specialized in dementia itself, so geriatric neurology, if you will. I'm boarded in neurology, and my present positions at OSU have a couple different titles, if you will, but I'm a clinician at our Memory Diagnostic Center. So it's our faculty practice where we see patients with memory loss and memory concerns. I also conduct dementia research and clinical trials. In fact, saw a participant just this morning. And most recently was promoted to professor in neurology and psychiatry. So hopefully that puts me in good standing to be able to chat with you today about dementia. Just to review some of the objectives that we set forth for today's talk is a primer in dementia. It's a term that we hear an awful lot about. I just want to make sure we have some common, clear vocabulary about it. We'll talk about surveying some of the leading causes of dementia. You'll soon learn that dementia is an overarching term. So we'll focus on Alzheimer's disease and frontotemporal dementia. That's been in the news a little bit. But in terms of breakthroughs and advances, we're going to talk about the new molecular tools that are available to derive a diagnosis during a person's lifetime. Perhaps you've heard in the past that you can't make a dementia diagnosis until someone has passed and we can look under the microscope. That's no longer the case. We actually have tools to be able to evaluate folks while they're still with us. And then we'll discuss some of these breakthroughs that have been in the headlines in the last couple of weeks and months, as it were, in terms of treatment advances that are already available or soon to be available. And we'll see how we can empower this whole crowd about how we can do some healthy aging. And with that, let's get to that dementia primer. So what is dementia? So like I said, it's a term that's used an awful lot. We see it in the press, but let's get to some of the nuts and bolts of it. So we diagnose someone with dementia, cognitive, some memory issues, behavioral symptoms that may come part and parcel. So it's not just a memory issue. It can be judgment, problem solving, language issues. And it's at a level that is not just a one-off, but is happening at a pretty consistent rate and frequency, and is now interfering with work or your usual activities. And furthermore, it represents a decline from a previous higher level of functioning. So imagine, if you will, an accountant who's now having difficulty balancing their checkbook. I know people are doing auto pay nowadays, but still an example of someone who would have been facile with numbers is now struggling with some basic arithmetic. But one of the questions, or a common theme that came up in the questions, is what about MCI? So mild cognitive impairment is this kind of in-between stage. So we will start here with this yellow line. We now know that changes in the brain that head towards Alzheimer's disease start decades before the diagnosis. And then there's this maybe gray zone pivot point where you're having some problems every now and again. Your brain's still able to compensate for that fairly well. And then we have the more formal declaration where friends and family and everyone's noticing more consistent everyday changes. This is that point of decline from a higher level of function and now interfering with activities. So for those of you who are queried about what is this mild cognitive impairment? In some circles, mild cognitive impairment can be due to sleep disturbances, medications you're on, mood disorders. Not all MCI leads to Alzheimer's disease. But to be fair, this mild cognitive impairment is this kind of middling stage then, somewhere in that transition zone potentially. And as I mentioned, dementia really all by itself as a word is not a diagnosis. It's a statement about, it's an umbrella term where we're having memory, thinking, language, behavior changes, and again, that interference with your daily life. So this is really substantial, not that you took the wrong turn the one time, but you're pretty consistently getting lost on your way to the grocery store. Among the key players is Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and a few others. But those top four are the ones we'll spend a few minutes, next few minutes, going over and having a little bit of a survey of. So dementia is the overall overarching term, and then I will often tell my patients that we have to give it a flavor. Which kind of dementia is it? Be it Alzheimer's, vascular, so forth. So here's the survey. These are the four that you saw in the previous slide that we'll go through, providing the abbreviations that are often associated with them. So Alzheimer's disease is often called AD, frontotemporal dementia, FTD, vascular dementia, and Lewy body dementia, and the common abbreviations associated with them. And we'll take them in this order. So as you can see, Alzheimer's disease is the majority of all dementias, which is why the popular press will often use them interchangeably, incorrectly, but interchangeably. It's the main flavor, right? It's the vanilla of the dementias. So 75% of all cases, we see a female prevalence, meaning that we think this is because, as you see where the average age is over the age of 65, we know from population basis that there are more women and women outlive men, and maybe that's what's being reflected in this female prevalence. There are estimates about what percentage of the population may have Alzheimer's disease at any given age. So it's a 10% risk at about age 65, and goes up to, depending on the source material, between 30 to 50% by age 85. So Alzheimer's disease is not an inevitability of age, but admittedly, if I'm seeing somebody in my memory clinic who comes to me with a memory concern and they're 90 years old, I'd be hard pressed not to at least consider, not jump to, but consider Alzheimer's disease as a possibility. And this is a little bit of where those numbers come from. So the Alzheimer's Association puts out a fact book every year. These are data derived from a 2014 study, but these are the ones we're still quoting. So in the 60 to 74 range, you can see where that 10% number comes from. Even across all races and ethnicities, we're seeing this kind of increase, 75 to 84, and then 85 on up. So I think Alzheimer's disease, a lot of us have a sense of what it is, that we know it when we see it. These are people who are having short-term memory problems, so they can remember what they did back in the day very, very clearly, but what they had for breakfast this morning or dinner last night might be a little fuzzy. A little bit more difficulty with multitasking. So in their 30s, they could do 5 things at the same time, and now maybe doing even 2 things at the same time becomes a bit more of a struggle. They may have some language issues and that of word finding, the thing that you write with, the whatchamacallit. And we now know that mood disorder, whether there's anxiety or depression, can precede Alzheimer's disease by 5 or more years. This duration number is a funny number because we're getting better at diagnosing the disease earlier and better end-of-life care as well. So this is kind of getting to be more expanded in terms of total numbers of duration. Occasionally, I'd like to mention people in the news or notables, just to put a picture to the disease. So Ronald Reagan, President Reagan, was diagnosed with Alzheimer's disease in 1994. And the National Institutes of Aging's pathology criteria, so the microscope criteria for Alzheimer's disease, are now in his namesake. Pat Summitt for the Lady Vols, the winningest NCAA coach. Glenn Campbell, there was a special about him on CNN that was circulating a few years ago, and Gene Wilder, the actor. So I like talking about Alzheimer's disease first because it's that majority, the thing that we most recognize as being dementia. And now we're going to kind of take a branch point from that and now talk about frontotemporal dementia. So here it's a constellation of a couple of different disorders. First one is what used to be called Pick's disease, more recently behavioral variant BV-FTD. You can see that's about 60% of all the frontotemporal dementias. So these are folks who have their frontal lobe, that's where your filter is, and temporal lobes, so where your language centers are and comprehension centers are. So as you might expect, if their filter is affected, that they have these florid personality changes, really don't understand that their behaviors are not in keeping with social norms, not socially appropriate, and can be problematic. So while the family may adapt to it, but you take this person out in public at a mall or a public gathering, and they can have some inappropriate behaviors. You'll see that it doesn't mean that they can't also have language difficulties or memory, but they're a lesser part of the symptoms, or later part of their symptoms. The next part here is primary progressive aphasia, so PPA. Northwestern is a leader with Dr. Meslam in this field. It's kind of an entity that he is largely credited with having defined. And that's another 20% of the disorders here. So these come in two flavors. One is a non-fluent language problem. So these are people who are having language issues primarily that are getting worse over time. That's not due to a stroke. So most people think about language problems in the setting of stroke. So this particular subtype, they lose their connecting words. Ball, boy, kick. Kind of get the sensibility of what's being said, but all the connecting words are not there. It can be very telegraphic. They can have spelling errors. So they'll spell square, S-W-A-R-E. Close, but not quite correct. The next variety here that is semantic dementia, the remaining 20%, these people have a great volume of language, very, very fluent, talking all the time. And yet when you listen, there isn't much content. And they lose word meanings. You ask them to pass you an apple and they might pass you the remote control. So the object and the name connection isn't there. And these folks can be a little bit more like Alzheimer's disease, where they can have those memory changes later in the disease. We've maybe heard a little bit more about frontotemporal dementia, or FTD, after the diagnosis of aphasia by Bruce Willis and his family back in March of 2022. And then that was further upgraded and updated to FTD as a diagnosis in about a year ago at this point, April of last year. So a lot of it, while a sad story for the Willis family, is brought a great deal of attention and awareness to the public that not all dementia is Alzheimer's disease. Frontotemporal dementia is not a particularly frequent entity, but certainly is very different than Alzheimer's disease. And more recently, we've heard about Wendy Williams with this condition. So moving on we're continuing on our survey of the most common dementias. So vascular dementia, you'll notice this squishy number of second or third most common dementia. I think it goes underappreciated. It's another slice of the pie, about 10% or so. So these are folks who have memory and thinking changes time locked to their stroke. So they have a stroke, they have a new them in terms of the memory and thinking capabilities, and that's their new norm. And were they to have another stroke, then there's a new norm after that. So it's a stepwise decline associated with strokes. And because of the cause being strokes, it doesn't just have to be a memory problem. It can be a language problem. It can be a movement problem. It can be a judgment problem. So it has more to do with the territory of the brain that was impacted by the stroke and then the consequences after that. You can think about these as being potholes in the highways of the brain, and you're just having a hard time communicating between the key regions then. And then the last one in the survey is Lewy body dementia. So again, there's another number of maybe second most common dementia, another 10 or 15%. Here, despite the fact that the age of onset is comparable, maybe a little bit later than Alzheimer's disease, it's male predominant. And these individuals may have a bit more rapid course, and there are a few reasons for that we can get into later, about 7 to 10 years. So in that same scale, I was saying Alzheimer's is 8 to 12 years, longer span there. It's a little bit shorter in that regard. And these people have combination features of Alzheimer's disease and Parkinson's, and yet it's a separate other entity. It's not just Alzheimer's plus Parkinson's. So these individuals can have deficits in visual spatial perception, just kind of their orientation in 3D space, difficulties with executive function. So the fact that a recipe, you have to follow it in order, C follows B follows A, and they kind of get that muddled. They can be more inattentive. And another entity where language and memory are a little bit more spared. Kind of formal criteria for this, but important things are you can have some elements of Parkinson's. It doesn't have to be Parkinson's disease, so slow movements and tremors, stiffness. They characteristically can have visual hallucinations. So they are not just shadowy figures, but rather fuzzy animals, kids, and the patient themselves are not particularly threatened by it. It's very troublesome to the family, but the patient is actually fairly sanguine with this. They can have fluctuations in their attention, maybe seeing like they're staring off into space. This is not sundowning. This is like throughout the course of a day or over a period of days. And they can tend to act out their dreams. So in our dream state, REM sleep, we are dreaming that we're falling off a cliff, but our body, in fact, is not falling off a cliff. These individuals may become very active during that stage. So that's our survey. It's a pretty rapid fire survey of the most common dementias. Let's move on to our next part because we got to get to the breakthroughs, right? No, that's right. A few famous people there as well. So the thing is, I just told you that dementia is when you are off your game in a consistent manner. It's interfering with your life. How do we start sorting amongst all these different possibilities? So we will often anchor to Alzheimer's disease, like that's often the most likely in our age range. But then we're listening for those other unique features. So maybe someone's had a stroke, maybe someone's having those characteristic visual hallucinations, maybe they're having a filter issue where they're not managing the behaviors very well. That helps us kind of lead away from Alzheimer's disease and go into these other categories. So how do we go about sorting all this out? So we have our kind of typical workup in clinic, clinical assessments. We're interviewing. It's an interview about the patient, of course, about their memory and physical health, and but we need somebody else's eyes, right? So we're about to meet them for 30 or maybe 60 minutes, depending on how the clinic is set up, and it's going to be a snapshot in time. So it's very helpful and, in fact, necessary in our clinic to have a person who knows you well to be able to accompany you and answer those kind of 365, 24/7 questions. Insights about whether these are, consistent difficulties you're encountering, and are they really interfering with who you once were. We add to that some cognitive testing. These are paper and pencil tests. They're measuring these different elements of your memory and thinking, judgment, and so forth. And that's just to get the ball rolling at kind of our visit. There may be more testing involved, and let's take a look at that. So we'll often want an MRI, so a good high quality image of one's brain. And we can take measurements of various structures. We can look specifically at language centers, short-term memory centers, and see if there's patterns of change there in terms of brain shrinkage that might explain the symptoms that someone's exhibiting. Not for everyone, but when we think it's appropriate, we may talk about doing a lumbar puncture or a spinal tap. Now, in our business, we realize that neither of those terms sound great. And are intimidating. We do them all the time. They're very safe to do. Not for every patient, but we do them when needed. So one of our colleagues who led our research efforts with spinal fluid said we need to rename the LP, which is normally for lumbar puncture, as a lovely procedure. And we have a branding issue, so we just need to get a little bit better at that. Point being, though, the spinal fluid is bathing your brain and spinal cord. It acts like a shock absorber. And so short of doing a brain biopsy, which we wouldn't do for a diagnosis, this is the next best compartment to get information from. So you can safely collect a couple of tablespoons of fluid from your lower back, well below the level of your spinal cord. And then we look for proteins that we now have learned are changing well before symptoms have even started. We'll show you those in just a minute as well. So starting with the MRI, we have someone here. This is if you were to look straight on them, someone who has a healthy brain, who's not having any memory and thinking problems. Short-term memory centers are very full here. There's supposed to be highways through the brain where the spinal fluid ought to flow. Those are looking good here. These various crevices are about a pencil tip width, and that's appropriate. And in contrast with someone with Alzheimer's on the other side, so short-term memory centers are a little bit more spacious. Room. So you can imagine the skull can hold brain and spinal fluid. So if we're seeing more of the spinal fluid dark space here, that suggests that there's been brain shrinkage as a trade-off. Language center would be over here. You can see that has a bigger gap. Those highways are looking a little bit more rounded out instead of boomerang shaped. So we don't make a diagnosis of Alzheimer's disease from the MRI, but certainly if the story that we're hearing from a loved one or a caregiver makes us think about Alzheimer's, this would be very supportive of that. But here come the breakthroughs. So a little schematic to start with. So if that MRI was a little bit hard to interpret, we can see on the right side of this panel what a healthy brain would look like. See those increasing spaces around the short-term memory centers and those highways getting wider. And then by the time we get to more severe stages of the disease, there's hardly much of those short-term memory centers intact. But then on the left side of the panel here, we're going to talk about these proteins. So there's two key players in Alzheimer's disease. Tau, which you might recall was the one I studied when I was at Northwestern. It sits within the neurons. It helps part of the transportation system, getting cargo back and forth in the cell. But in Alzheimer's disease, it clumps up. So you have a clumping of the tau protein that sits within the cells. And then the other one, they may be hearing more about in the news, is the amyloid protein that sets up shop outside the cell. So you have a protein, good protein gone bad, on the inside of the cell and on the outside of the cell. And these are important, not getting into the weeds for no good reason, but this is kind of where those breakthroughs are coming from. All right, so I mentioned the spinal fluid. I mentioned that we test it when it's appropriate, but we now have the ability to measure those key players. That tau protein, and this is a version of amyloid protein, so the outside the cell and the inside the cell proteins, and we now understand that the amyloid level goes down, the tau level goes up. It's a specialized form of the tau. And we can measure this reliably. This is now a test that's built into our system, and it lets us know, it helps us rule in and out Alzheimer's disease. However, I told you that's not all the dementia that's out there. So it doesn't really tell us more than that. So it doesn't say it's not a positive test for something else. But this was a tool that's become very much integrated in our clinical practice. But it does require a spinal tap. So that's not for everybody. And certainly people are on blood thinners and so forth, or may have had back surgeries and may not be ideally suited for that. Well, wouldn't it make sense then if we could just have a blood test? You go to your doctor, you get your blood counts, you get your blood thinness levels checked, vitamin levels checked, and how about getting an Alzheimer's test? We'll say that in the last couple of years, there's been an explosion in this space. There's a lot of tests out there, none of which are yet FDA approved. However, the one I'm showing you here was developed here at WashU and is the leader in the pack. So we are expecting it to get FDA approved and covered by insurance, which will be the next challenge by early next year. But it basically allows us to take a blood sample and look for those same players. Okay, so we look for the amyloid protein, the outside the cell protein. We look at different versions of the tau protein, the inside the cell protein, and come to some of those same conclusions. Wouldn't it be nice if you just got a little score that says negative, positive? And we're there. And they're pretty darn reliable tests, very reproducible. So it's non-invasive. We're not talking about any kind of radiation from any scan, but it's not yet FDA approved. And because of that, it's not yet covered by any insurance companies. So this is out of pocket right now, about $1,400. But this technology wasn't there 10 years ago. I mean, spinal fluid testing has really been part of our practice now, probably for the last, let's say 15 years or so. And now in the last 2 or 3 years, we've been able to add this into our tools kit. The other question is, well, spinal fluid is a filtered version of your blood. And these are still approximations, right? We're still not really seeing whether these proteins are in your brain. So couldn't we just take a picture and see if the proteins gone bad are in your brain? We now have those tools. So you can now have a little bit of dose of radiation injected, and we can go look for the amyloid protein itself in your brain. So it's an amyloid PET scan. And so these are individuals with Alzheimer's disease across the top. And you can see it looks like a weather map, right? So hot areas are where there's a lot of amyloid deposition. That's what we'd expect to see in Alzheimer's disease. In the bottom panel, so you can imagine if I wondered if someone had Alzheimer's or frontotemporal dementia, this would be a helpful tool, because those folks are in the blue and green range. They have cold fronts going on. They really aren't accumulating amyloid because it's not an amyloid disorder. This agent was approved, FDA approved in 2013, and only in the last year has it become covered by Medicare by about 80% coverage. So we're still looking at about a $600 out-of-pocket commitment. But we can actually see, yay or nay, is the protein associated with Alzheimer's disease in your brain, yes or no? But Alzheimer's disease requires the other problem child, tau protein. So we now have a way of measuring that in a similar fashion. So different marker, different dose of radiation, a little injection, and then we can get a scan and look for where do you have tau deposits. Because if you have both amyloid and tau, safe bet that that represents Alzheimer's disease. So in a normal person, this is an elevator view of the brain. This is a straight on view of the brain. With age, you might get a little bit of accumulation of tau. In Alzheimer's disease, it's that short-term memory centers I pointed out earlier. And then we'll zoom over here to Pick's disease. Again, mostly this blue-green situation. So depending, there's some accumulation there, but it just doesn't have the same impression that you get with Alzheimer's disease. These other two diseases I didn't include in my survey today, but they have more Parkinson's type features associated with them in those dimensions. This was approved in 2020. It is not, it's FDA approved. It is still not covered by insurance companies, but as a tool we have, and we're hoping that at some point in time, we could have the ability to do both tests in the same day and kind of get answers in that manner. So you'll say, well, Dr. Ghoshal, that's great. All these new tools, we can be really, really certain about Alzheimer's disease, at least, if not, and ruling out Alzheimer's disease. What do we do once we find out that that's a diagnosis? What are our options? So up until 2021, these were the options that we had available to us in terms of treating Alzheimer's disease. These agents had to do with improving the balance of brain chemistry, specific components of brain chemistry. So category of cholinesterase inhibitors, you may recognize some of these names, like I'm using the brand names just for familiarity, not for any other reason. So Aricept, Razodine really never got a big market share, Exelon patch. So these are FDA approved for mild to moderate Alzheimer's disease. And then Namenda, working through a different brain chemical, was approved for moderate to severe Alzheimer's disease, and you take them in combination. You'll note none of these have anything to do with amyloid or tau. And so these were basically studies where we saw that on average, 1,000 people on one or more of these drugs did better on average than 1,000 people who didn't. The disease continued to progress regardless, but perhaps we gave you a few more better days, months, or years with this combination. But it really still wasn't getting to the business end of the disease. Now, more breakthroughs. So then in 2021, we heard about Adhucanumab, or in publicly held Aduhelm. This agent went right after amyloid. So if amyloid is accumulating and isn't getting cleared out of your brain, how about if we gave you a drug that could do just that? So there was a study, and those amyloid scans again. So PET scans, hotspots show amyloid. So folks, day 0, quite a bit of amyloid. A year later, if you're just on a sugar pill equivalent, didn't look different and probably worse, right? There's more red. And then with increasing doses of this medicine, which was an IV infusion, think a little bit like chemo. It's chemo style is what I'll say. It's not a chemotherapeutic, but in that style. You can see quite literally clearing out the bad actor. So you're actually doing something to the amyloid itself. So in the bar graph form, the starting gate, everyone was pretty even. Half a year in, with higher doses of medication, got more and more of the amyloid gone. And then with a year and change, even more remarkable decrease in the amyloid. So why don't we hear about this anymore? Well, back up for a second. So it was controversial out of the gate. There were 2 studies. One showed this improvement. The other one did not convincingly do so. So if you ever wondered about the FDA process, that's a talk unto itself. Long story short, it's like baseball. You have to call your shot. You have to call your shot before you start the study. And they didn't, in these studies, reliably hit those calls. Maybe sort of, kind of, but not really. So effectively, while this was the first one through the gate in this category of drugs, it is no longer on the market. But it was the beginning of the tidal wave to come. So next one is lecanemab, brand name Leqembi. This was approved last July. And I'll walk you through these graphs. There's a lot of information here, but let me show you what's going on. So with this drug, just going in this direction is increasing worsening dementia is what's being measured. So the sugar pill folks are in the black line. So they're declining over an 18-month period of time. And the green line are those who got the drug. So it's not that they aren't declining, they're just flattening that curve, something we learned during COVID, right? So if you flatten that curve, that means there was a 27% slowing of disease progression with this drug. So that's encouraging. For the first time, we have a series of drugs that are actually addressing the business end of the disease. Exciting times. As of now, we have probably at WashU about 200 people on this drug. We think we're one of the, from what we've gathered from peer institutions, we're a little bit ahead of the pack. We had our first, so it was approved July of 2023, we had our first person on drug within about 6 weeks. Other ways to measure the impact of this drug is, so dementia will progress. It's by definition a progressive condition, Alzheimer's disease here specifically. So again, the sugar pill folks, this would be their march through the scale. So this is worsening dementia. And again, it's not that the folks on the drug don't progress, but gosh, they split off pretty darn early. So even at 6 months, we can really, was 3 to 6 months, we're really seeing them peel off. So here that was calculated to be a 31% lower risk of converting to the next stage of Alzheimer's disease. And the last one in this series, we need to do at least what Adhucanumab did, right? Which is show that you could clear out the amyloid from those PET scans. And that's what happened here. So over a period of 18 months, the folks on the sugar pill, they maybe got a little bit more accumulation of amyloid during that time. And even as early as at 3 months with this drug, there was a substantial clearing of the amyloid protein. So any drug now in this class has to at least be able to show this. And so that was the one that's been on the market now for a better part of, we're coming up on a year. But the one we just heard about last Monday, talk about timeliness of studies, is Donanemab. To be fair, we knew about this drug. What data I'm showing you were presented a year ago at the International Alzheimer's meeting in Amsterdam. But what we heard last week was the first level of FDA approval. So the FDA has an advisory group. They've looked at the study, had some concerns because it's a non-traditional study design. I won't get into weeds on that one. So they want to kind of hit the pause button and just make sure they understood what it was showing. But it does even better. So these kind of similar ways I'll show you. So here, this darker color, navy blue, let's say, is the sugar pill folks. So again, we're increasing dementia in this direction. You'll notice they went well beyond, in that year plus a year and a half range as well. But the folks on Donanemab, it does not yet have a cute brand name, the shorter and easier to say. But these folks split off pretty darn early as these weeks now. So even at 6 weeks, 6 months rather, sorry, it's a measurable difference. So another slowing. So in comparable terms, Adhucanumab, the first agent, had a 22% slowing of progression. Leqembi, the one that's on the market right now, is at 27%. This is now 29%. So with each kind of iteration of these medications, we're seeing more and more improvement, more and more impact on the disease. In this left panel, tau comes back into play. So it turns out that if people have a low tau burden, they don't have as much tau accumulation, they're probably earlier in the disease, and maybe the ask of the drug isn't so much. So maybe you can game your patient population by finding people who are at the earliest stages, and is this drug then more impactful? And it appears to be the case. So you see the split off even being of a larger magnitude. So now there's a 36% slowing of the clinical progression. So now we have 2 agents. Similar staircase, so progression to next stage of dementia, again, splitting off with the drug. So it's a 37% reduction. So these numbers are just getting bigger and wider. If you look at that more discrete population, the earliest, the least burdened individuals, they split off even more. And we have now a 38% number. I got to say, a lot to take in, right? And a lot of new opportunities here in terms of drugs available, but it's not for everybody, right? Some people are just not early adopters, are not yet comfortable. These medications do come with side effects. There is a risk of brain bleeds and brain swelling. We are trying to triage people appropriately and give them the best advice moving forward. So the question a lot of you guys had was, what if I don't yet have memory problems? I want to keep from having memory problems. I'm not going to qualify for these drugs yet. I have some thoughts for you. So even as early as these data are from 2015, we knew there were a number of lifestyle factors that one could look at and are impactful in the progression towards cognitive decline. No surprise, we've heard a lot probably about traumatic brain injury. We hear about football players, obesity in midlife, high blood pressure, smoking, diabetes. These kind of in aggregate are vascular risk factors, making your blood vessels less happy. History of depression or lack of appropriate treatment. I mentioned mood disorders earlier. Sleep disturbances, sleep apnea, high cholesterol. But we know that there's some protective factors. So say years of formal education, this is the thing that's easiest to measure. It doesn't mean years of college necessarily. It can be even on the job training. Physical activity, the Mediterranean diet. I'll say more broadly here, this is farm to table, right? So less processed foods, keeping the mind engaged. The alcohol question is always a little dicey, but some modest amounts of red wine, for instance, would be okay. And social engagement, because we are social creatures, staying socially engaged is also protective or decreases your risk of cognitive decline. So we need what's a prescription, right, for lifestyle modifications. So in 2019, the World Health Organization, WHO, came up with this infographic that we take a look at. So as you notice in the previous graph, diagram, that so many of these risk factors that are modifiable. A lot of them have to do with good heart health and brain health. So same old blood vessels get you in trouble with your heart, get you in trouble with your brain. And everyone's always looking for an answer here. So maybe 2 days a week of moderate aerobic activity, resistance training. I would add to this. I have people who are swimming, Tai Chi. I have Parkinson's patients who are boxing. But it's to each their own. So there are a lot of even my colleagues will have prescriptions for how much physical activity. But I will say that if the most activity you do now is going to the end of your driveway and checking your mail, we got to do a little bit better than that, right? So maybe around the block. And so we want to make sure that these are realistic goals for any given individual, but physical activity is good. The evidence for that for people who are cognitively healthy, quite a bit of evidence even in 2019. It made good sense that it would be also helpful, but not as robustly shown for people with that mild cognitive impairment, that kind of pivot point between being very, very healthy and on potentially the slippery slope towards dementia. We've learned more since 2019. So in 2020, a study that I was involved with, so I studied frontotemporal dementia. We have folks who have hereditary forms of this, where it's hardwired in their DNA. They will develop the disease. So we followed them over time, and we asked them to tell us, hey, how much physical activity are you doing? How much cognitive activity are you doing? And in hearing from them, people say this isn't great quality research because people will tell you stuff. But if we use the same surveys and ask people to self-report, we learned a few things. So if you go from the blue to the red, so you go from low physical activity, you're saying that you're not doing too much, to higher levels, you can meaningfully, again, flatten that curve. So this is clinical decline going in this direction. Okay, going up is worse cognition. So you can flip the script. So just by going into a higher physical activity level, you can better maintain your cognition. Similarly, when we ask people to do more cognitive activity, they could go from I don't do as much. I was worried when I have patients say that they don't have hobbies. So we can get something going, get some activities going for them that keep them cognitively engaged. They can also flip into this pretty flat line. It's going to maintain over a course of 3 years, pretty stable cognition. And still in this population, a few more pieces that we learned. So again, the same setup. So if you went from low physical activity to high physical activity, you could maintain memory testing scores. So this is the MoCA, the Montreal Cognitive Assessment. You can actually improve or maintain a high score. This score here, we'll come back to that in a second. If we talk about physical activity, same idea. You go from a low level activity to high level activity, you actually speed up on these time tests. And then this last one, this is a grouping of a number of memory tests Same idea, go from low to higher. Here we're also looking at this was the inevitable brain shrinkage that this population could expect. So that was going to happen, and you could buffer the effects of it by keeping physically and cognitively active. So physical activity allows you to have a higher maintained MoCA score, faster reaction time on the Trails ACE test, even cognitive activity, and maintain your memory performance. So these are things that each of us on the call can do here now. And then just 2 weeks ago, as we were talking about getting ready for this talk, there was another trial. It's got a good amount of press. This was a study done, it has all the right words. It was randomized controlled clinical trial. It was done out of the Bay Area, UCSF, Mass General hospitals. Pretty intensive intervention across the board of counseling, meditation, yoga, diet, and making sure there was a lot of counseling to kind of keep you on track for a 20-week period of time. Of course, this was initiated and executed during the COVID era, so it did minimize the total number of people they will enroll, but it was 51 people in the study, 25 and 26 who did or didn't get this intervention. Just rest assured that those folks who didn't eventually did. That was a promise to them. Not as very clear graphics, I will say. So here again, in this direction is decreasing dementia. So the folks who did their own thing, right? They weren't really given a prescription for intervention. You were allowed to just figure out what might work for you. Even in a 20-week period of time, they showed changes in their overall cognition and function. And those who got this pretty intensive intervention, though, in a 20-week period of time, went in the other direction. They got better. There are a lot of questions about supplements that had been sent in. So I want to pop this up. These were actually the prescribed supplements in this last study that I mentioned. So omega-3 fatty acids, curcumin, the turmeric business. What I'll ask you to do is I won't read every word out for you, but you'll see that there's some studies referenced, but they talk about may reduce, may have a protective effect. So none of these are slam dunks. I will further point out that for vitamin B12, they say, yeah, if you have a low level of vitamin B12, that has been linked to Alzheimer's disease. And so we all check vitamin B12 levels and we'll supplement it only if you need the supplementation. Same thing with magnesium. There have been questions about lion's mane. I can get into that a little bit more. But overall, with supplements, they're just not regulated the same way by the FDA. So batch to batch, we see this with curcumin a lot. Batch to batch variability, how you're going to respond at any given time. Lion's mane can interact with other medications you're on, cause unpredictabilities in blood sugar, blood thinners, and your immune system. So if you're on immunosuppressants for an autoimmune condition or a transplant, lion's mane may interfere with that. So we just need to understand that supplement isn't inert, it's not innocuous, and you need to be telling your doctors about what you're interested in taking, what you may be taking, so we can think through what it might be interacting with. So there's a lot that we covered today. It's kind of the last slide before we go into the Q&A. And a lot of familiar themes, right? So we can even talk about separate from dementia. We can just talk about healthy aging. So hopefully the most of us who are on the call today are in this time frame of life, if not earlier. And there's all these things that you can do to empower yourself in the here and now. So we talked about levels of education, whether that be formal or on the job. Mentioned meditation in this last study. Things like your vascular risk factors, your cholesterol level, blood pressure. People had asked about the microbiome. We can talk more about that in the Q&A. So it turns out that the variety of bacteria, that's what the biome is referring to, in your gut, that diversity decreases as we age. And as a result, we get this pro-inflammatory environment that does have effects on the brain as well. We didn't have that mind-gut connection understanding until the last couple of years. We think that, so if I'm talking about inflammation, then we maybe need to talk about something that's anti-inflammatory. Talk just quite a bit about physical exercise. Some of you asked about supplements like NMN and NAC and so forth. Those have a role of being antioxidants. All the good lifestyle stuff. Avoiding smoking, weight control, limiting your alcohol intake, or limiting your calories entirely. That was not done of note in this last study. They basically gave you whatever your caloric requirements were. Balanced diet, sleep, so overlooked. social interactions. We know there's data for this in social sciences that people who have more degrees of cognitive social interaction are sick less often, are hospitalized less often, have shorter hospital stays, so forth. So a lot of things that we're empowered that we could do in the here and now that keep us from even getting to the point that we're even having the dementia discussion. All right, folks. So ready for questions. Please use the Q&A feature for us to do so, although take a look in just a moment. But I do want to preface this next section. So everything I've provided you so far is data-based, evidence-based. But when I started giving answers to some of the questions, they may be more reflective of my own opinions, reflective of my own practice, and don't necessarily reflect the same thoughts that are at Northwestern or at Washington University. All right. So let me stop sharing. Thank you for your attention. Let's see what's going on in the question and answers. Okay. So we have a question is what is the intersection of dementia with Parkinson's disease? Besides that dementia may be a symptom of Parkinson's. Yeah. So common things being common, we see more Parkinson's disease in the aging population. And it turns out that a third of Parkinson's patients may develop a dementia, that's Alzheimer's disease like, and a third of Alzheimer's patients may develop Parkinson's. So we're certainly surveying for that at each visit. So there is an intersection. It's a little bit of a Venn diagram. So not all Parkinson's patients will develop dementia is probably the short answer on that. Are there any new treatments for patients with Alzheimer's disease who are in the intermediate stage? Fair question, not yet. So the thinking has been that I mentioned briefly, there was a 20-year lull that we had things like Aricept and Namenda before we had the new agents. And we think part of it was we didn't have the other tools, the spinal fluid in the blood, and the PET scans to really be sure that we're actually testing the right people in the clinical trials. And the other thought was we were maybe waiting too long. So everything right now is very, very geared towards the earliest, or primary prevention even. We're about to start a study here at WashU for that. And so as these drugs are launched, we are keeping very circumscribed, because they do have side effects, to kind of the parameters of the population that they were studied in. That for the moment is early stages. I think as we all get more comfortable with these drugs, we'll start loosening the criteria and offering it to more and more people. So there's a question about hereditariness. So an individual says that their dad had vascular dementia, mom had Lewy body, and they're concerned about their own risk. So as I mentioned, with vascular dementia, the risk that is due to a series of strokes. So if you have any of those risk factors, those are all modifiable. So blood pressure, cholesterol, diabetes. And Lewy body dementia, I think we have less of a sense of kind of how genetic that may be. I would say overall, when we always often harken back to Alzheimer's disease in terms of the wealth of information we have. So if you have a first-degree relative, you are at higher risk of Alzheimer's disease than the average Joe, but we're talking about like a 7% increase. So I think people worry that it's a 50 or 75% increase. It's like a 7% increase. So my advice to people when I see them in clinic is live your life, do the good, healthy living, but don't be overly concerned about your risk of inheriting the disease. Nice one. Okay, how did my time at Northwestern influence the focus of my work? Yep, quite a bit. So I was very, very basic science when I was at Northwestern, studied the tau protein in a test tube. I slowly shifted, though, to looking at folks who had participated in research studies, had donated their brains to science, and started looking at the changes, kind of the predictable changes that the tau protein in particular takes during an Alzheimer's disease. It made me go into neurology, and then maybe want to go into geriatric neurology and take care of dementia patients. So it very much influenced kind of those selections. The tau protein is having a resurgence, it's having a renaissance, if you will. So it's not anymore limited to Alzheimer's disease. We do see it in some of the other dementias as well, in frontotemporal dementia. So my knowledge, what I learned and studied at Northwestern is continuing to be very valuable here as well. Are we partnering with any current and new researchers? We are always, it's ultimately a very small fraternity. Ultimately, so we're all colleagues and collaborators. We reach out to one another, whether it's a mouse model, whether it's, hey, can you be a site that entertains the next drug that we're interested in? I have over time sent patients to Dr. Rogalski, who had the primary progressive aphasia, the Bruce Willis entity, because that's kind of her wheelhouse. And so she can do some remote testing and remote therapies. Yeah, there's so much overlap between neurodegenerative diseases. Is there any research that being done that could possibly impact all neurodegenerative diseases? So I think that last slide I showed you, kind of all the different impact points, right? So we think that we've probably been a little short-sighted in the dementia space, that we thought any one drug could get the job done. Cancer folks thought about this more smartly, at least for a period of time. They're now back to single agents too, but for a period of time, it was a combination of drugs, right? So we probably need a tau drug, we need an amyloid drug, we might need an anti-inflammatory, maybe we need an antioxidant as well. Okay, so I think we're looking at not staying in too many little silos, but what are kind of the broad impacts and the broad possibilities where those can we talk about the gut microbiome, and can we modify that? And can that influence Alzheimer's disease, or again, really dementia more broadly? If the drugs substantially clear the proteins, why do we still have progression in disease? Well, they are clearing a good amount of the amyloid. Are we still a little too late in the game? Possibly. And we're still not addressing the other things that are already kind of in the cascade thereafter. So we haven't done anything about the tau. Another protein is called TDP-43. Someone had asked earlier about late, so the limbic predominant TDP-43 related encephalopathy. Whole lot of words. But TDP-43 is another protein, another bad actor that we're seeing across the board in a lot of different neurodegenerative diseases. So that's not being addressed with these new drugs. So yet, I should say. Biomarkers seem to be so important. There's a lot of data. Is AI being employed to find biomarkers faster? Absolutely. Versions of AI, machine learning, certainly. So one of my COVID projects, when we were all unable to see patients and research participants in particular, it got into some data mining out of the electronic health record and looking at were there clues in the clinic notes that would help us pull out those folks with dementia. So we look at natural language processing, another version of machine learning, and there's an ongoing project now about using more ChatGPT 4.0 and other modalities. Yep, a lot of data, a lot of number crunching, a lot of looking for patterns. I will say probably the lead with AI in our space has to do with the imaging, looking for patterns of change in those MRIs. So MRIs are easy. PET scans can be tougher to get to, right? So in terms of easy access for patients and participants, they can get to an MRI scanner fairly readily. So what additional information can we extract from that? And can AI help us with that? If tau and amyloid are bad, are patients starting to proactively take these medications before accumulation can take place? These medications, I'm assuming you mean the Leqembi and the Donanemab. You're not allowed to, so we're still the gatekeepers for that. You have to come through a specialist. There are criteria they have to meet before we will even have the conversation about whether this is a drug for you. It's not yet so freely available. I should explain, I alluded to it. So Leqembi is an IV infusion, so an hour or so infusion twice a month. You don't get to travel very far because we have to be back for your next dose. The Donanemab is monthly, so it's looking to be a little bit more doable. And Leqembi is looking at a subcutaneous version, so think like an EpiPen that you'd be able to administer yourself. No trial yet combining Leqembi and Donanemab, but we are combining an amyloid drug with a tau drug. So that would be kind of stay tuned for future releases there. So there's some questions that came through before as well about genetic testing. How do we know if we are predisposed to having dementia by DNA testing? I wouldn't recommend it. The only test that might be worthwhile, and is the ApoE testing, and that comes, I'm kind of flavors kind of person, so it comes in 3 flavors: 2, 3, and 4. Don't know why there is no 1. There isn't. 2 is protective. 4 is not, is the one that puts you at risk. 2 copies of 4 puts you at higher risk for Alzheimer's. Now, again, not hardwired, puts you at higher risk for Alzheimer's disease, higher risk for bleeding from brain injuries and so forth. That has only recently become relevant. It was never a game changer. You could find out if you wanted to with a 23andMe type of thing. But now it helps us risk stratify people for Leqembi and donanemab. So are you more likely to have, more or less likely to have the side effects, the brain bleeds and the swelling is where that's been most useful. Can we do a MoCA or another test before we have symptoms to establish cognitive baseline? Also not advised. So I keep seeing people in clinic who thought they'd get a good baseline. It's really not advised for a few reasons. This is a bit of a rate limitation, and I would say it's not as useful in the absence of symptoms. So I think if somebody, I'll give you a question that comes up on the mini mental state exam, similar to MoCA type of test. So if you ask somebody today, what's the season? Ask yourself, what's the season right now? Given how blazes hot it is outside, you are apt to say it is summer. You would be incorrect. It is spring. So we actually look for the formal season change, calendar date change. So you'd miss a point. So these are kind of issues with each of these tests. They're very verbally driven. So if someone is having language comprehension issues, they're going to seem like they're doing quite poorly on these tests. And it's just kind of a feature of the test. So I wouldn't recommend it as a baseline. If you have a concern, it's a good tool. It's a good tool at that point. Question about Prevagen. So Prevagen is billed as a jellyfish protein that can help cognitive health. Here's the opinion part. I would not recommend it. So my concern about a lot of these supplements is they are not rigorously studied. They are very small studies, sometimes anecdotal. 10 people said it did something for them. I feel a lot better on it. They're pricey. And again, they're not kind of regulated very well. They're kind of supplements and they kind of fall in a different category at the FDA level. So Prevagen fundamentally becomes a protein that you ingest, and your body has no ability to process that differently, say, go send to my brain versus to my deltoid. So that's my thoughts on Prevagen. Again, that disclaimer applies hard here. Okay. How does one get to a referral to see a specialist to get prescribed one of these treatments? These are fair questions, right? So did we actually ever have the infrastructure in place to make this happen well? Start with your primary care physician. They can certainly do a MoCA type of screen, and they can get those initial blood work and a scan done and see if you need to then see a specialist. And then we can take it from there. So it can be a little baton handoff. Symptoms of Alzheimer's disease seem to be those of healthy aging, only more so. How do you know when your symptoms warrant seeing a doctor? Fair question. It's when it becomes more problematic. So let's say you're now, like I said, if you missed a turn the one time while there was construction being done on the road, that's one thing. If you come to the end of your cul-de-sac at the stop sign and you're wondering if you take a left or a right turn to get to your grocery store, right? So that's more substantial. Now with Medicare, there's the annual wellness visit. There's a spot in there for cognitive consideration. It doesn't even always have to be testing, but there's at least, again, a pause button to query how you're doing with a memory thinking standpoint. Quite a few questions about the genetics and getting testing. Yeah. About 3 in a row there. Genetic testing for children with early onset Alzheimer's disease patients. Potentially, right? So we do, so when we say early onset, let's define that so that by definition is individuals with symptom onset before the age of 65. It doesn't mean mild. It doesn't mean it's not that. It's just an age cutoff. So we do know that those tend to be more hereditary. I will say we studied them a lot at WashU and other locations. It's a much earlier onset disease, 30s, 40s, 50s, and very aggressive. And we see a clear pattern, it's dominantly inherited. So someone from each generation of one's family, we would expect to see someone affected. So we usually look for 3 generations and then say, yeah, that's probably a pattern worth investigating. Other hereditary aspects of dementia. So ApoE is really the risk factor that we think about. We do know that doesn't explain all the hereditariness. And so there's ongoing inquiries about what other maybe smaller players there are. But at this point, kind of testing DNA widely, I'm assuming someone needs like maybe whole genome sequencing, is really in the realm of research studies. Okay, I think we're at time and then some. Hopefully I answered a good number of questions, team. So that seemed like it was a great questions. I really appreciate the variety that were both sent in, and appreciate your attendance today, and hope this helped demystify dementia for you.